Good afternoon. Can you hear me in the back? Through this? Good. I'm glad. Thank you all for coming. This is Wednesday Geriatric Grand Rounds. I'd like to acknowledge some visitors. We actually have some first-year med students here in the research elective, so thank you all for coming. And these two gentlemen down here are classmates from the year 1990, St. Louis University School of Medicine. Michael Walters is in intensive care. Charles Tadros is a general internist, but he also does hospice. So they're very, very pleased to have him here. And of course, Nurses and Company, thanks for coming in and joining us. Okay, let me poke this up into... There we go. Okay, nothing to declare. I would like to remind us all that Grand Rounds is about the patient, and we can use the patient to catapult us into research and to improve other patient care. So this picture is taken from the internet. This is not the true picture of the patient, but it really, really looked like the guy I was taking care of. Matt Burr, who's not here, was the nurse practitioner. He helped me through this case that we had. Admitted last August, and the main reason for coming was mental status change or delirium. And when I saw him on that first day to take over the service, really unresponsive. Okay, had the fracture. And here was the first 10 days of his hospital course. I left a lot of this out under intervention. So under the intervention, I'll talk about what happened during the first 10 days. And then there were some other interventions later on, and we'll get to more details. But for literally the first 10 days under our care, we didn't see any change in his brain or his physical function. Very frustrating, as some of you may attest to. So our objectives, first two for most of this group are going to be preaching to the choir about what's the current situation in hospitals for older people, and then some key beneficial principles for older people. I'll focus a little bit on that, but then number 3 and 4 is where the meat of the lecture I hope we can discuss, is why would a hospital, why do we need a hospital to succeed in taking care of older people? And now what are some other side benefits? It's true that even one hospitalization for an older, frail person could change their life. We hope it doesn't, but perhaps we've all had stories of our own family members even. The history behind some of this is not the entire history of hospital care in the world, but in the past 25 years, we started looking, we meaning the medical world, started looking at the dangers of the hospital in the early 80s, started publishing in 90s. So this study comes out of the early 80s in New York State. And these numbers don't look that dramatic. 3.7% had some adverse event in the hospital. You're like, okay, they might have fallen, they got the wrong drug, they got aspiration pneumonia. But when you think about 13% of those 3.7% resulted in death, then you start to get startled. So you don't have to do the calculation, I did it for you. 13.6 of 3.7% is 1 in 200. So back in the 80s, 1 in 200 admissions in New York State resulted in a death from an adverse event. That's not very good odds. Maybe it's a little better in the late 80s and when this was published in Colorado and Utah. 6.6% of 2.9%. That turns out to be 1 in 500. I guess if you're going to get sick, go to Colorado and Utah. Don't know what our numbers are here in Missouri. But after these two major studies came out, people started to realize, yeah, the hospital is a dangerous place. According to Morton Creditor out of Kansas University, 1993, that was not the name of his article, but that was my take-home message. I was a resident. We were all residents in the early 90s, and this guy named Morton Creditor, where I did my residency, published this paper, and he was a pretty soft-spoken guy. I was shocked that he would write some article about how bad the hospital was, right in the middle of our training when we think, hey, we're learning to do stuff. But made a difference in my life. Then this is for the physicians as well as the nurse practitioners and nurses in the audience. We either say this on rounds or we hear this. And for the students, again, I don't want to give you a negative lecture, but you have a bright future. But you'll be struggling with this when you're a resident. Why can't the patient get out of bed? What really happened in the nursing home? Just a few of our daily frustrations. Now, here's what happens, I think. This is my opinion based on 25 years of experience, I guess I could say. The problem with us identifying the adverse events and preventing all this problem is that the bad events get diluted. If we think we can change something on rounds during the 2 weeks we're on service, we're fooling ourselves. It seems almost unchangeable. And then these things are complex. First, diluted. Here's data. This is, I think, one of the sentinel studies in the 90s. This was a prospective observational study at 5 different hospitals. These are all internal medicine patients. And they looked at ADL function while people were in the hospital. And then they followed them up for 3 months. 3 months. And if you took 100 people, their study had 1,279. If you took 100 people, here are the numbers. Of those 100 people in the hospital, all older people, internal medicine, 70 years or older, 30% will lose some ADLs in the hospital. 30 of them. Not a big deal, right? So now you go out 3 months. How many of these 30 people that lost the ability to dress or walk a little better or eat, feed themselves, of these 30, how many get it back? Only 3 are going to get it back. 90% lose it. They never get it back. Never get it back. Now, why is that? There are many reasons. Here, I'm going to go through some of the most obvious. I'm going to do a little geriatric barometer here. So what's your gut feeling when you see this? Anyone want to throw out a word or two? Not a sentence, just throw out a word or two. What? Overwhelming. Anybody want to say fake? If I could use Elaine's words from Seinfeld, you guys probably know this. Fake, 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 fake. Some of you might get that joke. How about this? Yeah, what is something bothering you when you see this? It really bothers me to see this. But this is our usual routine. Bothers me to see this. These are real. These last 2 are real photos. But all the doctors are happy. Patients are happy. And it bothers me that the bed is still the center. And in fact, I'm watching your faces, and I can tell that now you know this is the reality. This is real. This is that 30% that lose function, 90% never get it back. Never get it back. So not only is the bed the center, one of the problems, what about the bathroom? Where is the bathroom in patient rooms? It's always behind a door. And you and I might think much of that, but I'll never forget the lady. I walked in to Pear one morning, not too early, but she was going to the bathroom. Her bed was here. Her IV pole was here on this side of the bed, and her bathroom was over here. And she's got her arm out with the IV attached, lunging or reaching for the bathroom door to try to open it. If I hadn't come in early, I guess she probably would have reached or pulled her IV or something. So these are simple things. Again, Elaine from Seinfeld, fake, 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 fake. Reality. Very much reality. I mean, how can these people eat? Wait till you guys are third years, the first years. The assignment I give the first years, or the third years on rounds is go home tonight and eat dinner in bed. And then come back and see how it feels. Again, fake, fake. Has anyone ever seen a patient in the hospital walking alone with a walker? This. No one's holding on to her. My God, no one's holding on to that lady. Reality. Reality. And, of course, there's the noise and the hard floors. Then there's all this routine care that can drive anybody crazy. I'm never quite sure why it ever happened that doctors, I know it's a Medicare rule or something, I don't know why doctors have to order PT and OT. It's beyond me. And then, of course, the gowns, SCDs for the students. Those are sequential compression devices, otherwise known as ankle bracelets that don't let you out of bed. Had a patient at the pair get out of bed in the middle of the night with those on her legs, and, of course, she fell and hit her head when she climbed out of bed. Okay, so one of the challenges here is culture, and I only have 3 slides on culture because I really hate to even think about it as well as talk about it. But this is a small survey of senior healthcare executives, and they admitted that the biggest stumbling block for them is culture. It's not funds. It's not priorities. It's how do you change this culture? What do you do with it? Now, culture does have some benefits. We all walk in, we know what to expect in the culture that we walk into. If we change the culture in a hospital every week, we'd probably get even more frustrated. So there is a reason to have a culture. People feel comfortable, but it's probably the biggest challenge. So I would agree with this guy. I think this is one of my mottos now. Based on, do we really need a geriatric hospital? A whole hospital? Well, if you're going to change culture, I think you have to change everything. And here's the example. Is now at DePere, where we used to have a really pretty high-functioning ACE unit. We only admitted older medical patients there, rarely an older surgical patient. Now, because of lack of bed population, they've mixed young people with old people. We still try to do the principals. But now you have nurses down there that aren't the geriatric nurses. And so now the non-geriatric nurses are questioning, why do we do this? We don't do it with the young people. We don't do it with that person. And so you're battling day after day to say it's good to do this. Because, well, we don't do it for everybody. So, again, just a little, I hope it doesn't sound like I'm preaching too much, but just so you know the basic problems we're dealing with. Then this, complexities. Don't have to talk about to you guys how complex it is to take care of a patient, but I put this up here to emphasize a couple points. Before someone comes in the hospital, that's where most of things are going on that we never even pay attention to in the hospital. What were they like 2 weeks before they came in? Do we even know that? Do we even know that? Then the ED. I just learned a couple days ago from a meeting I was in, the average length of stay, now they measure this in the ED, the average length of stay in the RED is 3.5 hours. Now, if you think that's the average, I'm sure there's a pretty good standard deviation. So can you imagine not only being young but older with kyphosis, not much fatty tissue, laying on a gurney for 3 of those 3.5 hours or 4 or 5? It does. It includes... After they check in, that's what that is. Yep. Well, no, this is an average, so you do have the standard deviation, which they didn't give, so you can imagine. Yeah.
So that's the 3-year-old who comes in and needs something or he's sleeping.
Yep, in and out. So. If we just focused on the hospital, again, the case for the geriatric hospital, here's some of the predictors of outcomes. This list is probably longer as I put X, Y, and Z down there. You can read that as well as I can. I think one of the bigger areas we could have an impact would be the immobilization. So on to number 2. Are there any models out there that we could take and use the principles of those models? And, of course, there are. Here's the alphabet soup of geriatric models. I'll go through a couple of them, or a few of them real quick here. Comprehensive geriatric assessment, yes, it does work. Improves your odds of living at home up to a median of 12 months. That's what the studies went out to. It even improves your odds for death or deterioration. So it does improve mortality if done well. The ACE unit, we have one here at SLU and one at DePere, acute care for the elderly. Not a lot of studies out there. but it does barely improve functional decline or reduce risk of functional decline based on that. Odds of living at home does not reach statistical significance. Again, not huge numbers. Mortality does not improve mortality. Now, I would still say, again, you're not supposed to do this, but I'm doing it. If you triple or quadruple the numbers, you're going to have some good impact. Okay? It's going to take a lot of people. And if you measure the number of people that we have in hospitals over a period of a year, you're probably doing a good job. All right, the HELP program. Hospital Elder Life Program. It's based on prevention of delirium. Here are the basic principles are older people come in the hospital. You screen them for risk of delirium. These are med-surg patients. I'm sorry, the study only did medical patients, but there are no ICU patients in this study. You look to see if they have any risk factors for delirium, which you can read there. They randomized them, and the intervention group got quite a big intervention. Time intensive, people intensive, and I'll come back to this one, this ambulation, in a second. And they were able to reduce delirium by about a third, which is not bad. They did it in one hospital, so there was the Hawthorne effect where people started to do stuff that they were doing in the intervention group. So still pretty good numbers if you can do all these things. Now, talking to the author of the research project in the paper, she said probably the best thing they did was the ambulation. And who did they do that with? She did it with hundreds and hundreds of volunteers, trained volunteers on how to ambulate older people. But it was not PTOT, who you're waiting days for the person to see. So it can be done. Ambulation, ambulation, ambulation. There's a website if you want to go to it. Our own model here at St. Louis University, the Delirium Room. As you know, delirium is associated with all the hospital complications. This should be increased nursing home placement, increased hospital stay, increased mortality. So delirium is a bad thing to have. Here's the data on mortality. You can see that mortality in 3 of the 6 studies is statistically higher in delirious patients compared to non-delirious, even if you control for other factors. And even if you go out 6 or 12 months. This has always shocked me. Why? You can get people through the hospital with the delirium, but why does the delirium have an impact 6 months and even 12 months down the road? And probably, here's why. We think that the duration, the longer you're delirious, it actually affects the brain and maybe even the severity. And I didn't put the studies in here, but there's an ICU study out of Vanderbilt that shows this, that the duration and severity affect brain function 6 months and 12 months down the road. And then there's a study of inpatients that looked at outcomes 3 months later, and it showed that delirium severity decreased your outcomes later on even. I'll show you this because this is a real patient, and this is probably more important, more impressive than those studies I just told you. 49-year-old person with sepsis, of course, so there's that factor, but somebody who was clearly delirious throughout her ICU stay, and her brain took a hit. You can see her pre-illness IQ was 140. She was some kind of professional, and she thought it was important to have her IQ on her CV or resume, and so she kept following up and kept going to the doctors after. I say, something's wrong, and they'd say, you're fine. They do the little mini-mental or this or that, and they'd say, go back to work, and she'd try, and she just couldn't do it as well. So she finally told someone, and they retested her and found out, yeah, you have a problem. Okay. So back to our delirium room. It's restraint-free. We always have a nurse in there, 4 beds. Here's what it looks like. The key factor here, I think, almost every day we get patients out of bed for meals. We're mobilizing them. We're walking them around. Always a nurse in there. Here's our data on mortality. I'll clarify some of this. This data from SLU is retrospective. The data from DePere is prospective, and then retrospective chart review to review the data. Prospectively at DePere, we identified patients delirious or not delirious. At SLU, we identified patients delirious according to the chart, and then took a sample and age matched them and DRG matched them. When we did the mortality data at SLU in actually it was the year 1999-ish, finally got it published, 2003. We didn't think much of this because it's such a small number. And then, again, we didn't think much of this. But then, around the world, people started opening up delirium rooms. Singapore, Hong Kong, there's 3 in Australia, at least 3. And the Australians produced their data, different sites, and their mortality data has either trended or became significant. So maybe if you can manage the delirium without drugs and restraints, you may have a chance of improving people's mortality. And this is just during the hospital stay. Okay, the ABCDE comes out of Vanderbilt, and it's a package deal, it's a bundle, as they say, and now they're up to F. They're ABCDEF, and F is the family involvement with ICU patients. Family involvement. But the AB is awake breathing. So every morning on the vent in the ICU, the team is supposed to turn off the sedation, wake the person up, let them wake up, and see if they breathe on their own. If they can't do it, obviously you turn back the sedation, keep them on the vent, and you're supposed to do that every day from day 1. I don't know the reality of this, but that's the way they published it, and they're doing it. Choice of sedation. Benzodiazepines are not the choice of sedation. The better one, that for lack of better sedation, is dexmedetomidine at this point. Hopefully we'll find something better. Daily delirium monitoring, and then early mobility. Here's early mobility. Picture of a guy, I think this is out of Johns Hopkins, but the original study, I believe, was up in Iowa. Schweikert is a physical therapist. I think the second author was an occupational therapist. All right. So they took patients, all intubated patients, quite sick. Many were on drips. Many had a diagnosis of sepsis, as you could see. And they randomized them. Many of them were young. The majority were young, under 70. And the intervention group got PTOT within the first day or 2. This group came and spoke to our American Delirium Society, and they said the reason the intervention group took so long to intervene was the consent process. It would take them at least a day. But I thought that was pretty good. Still within 2 days, they're mobilizing these patients. And you can see they're not walking on day 2, but at least they're out of bed, standing, transferring, walking by day 4. Typical is you wait about 6 or 7 days. I think they're stable. Let's order therapy. Early mobilization. Here's the outcomes. The biggest one I like is delirium days was cut in half. But you could also take functional status. At hospital discharge was better. Nothing dramatic here. A few more ventilation-free days. Mechanical ventilation days. Extubation rates were about the same. They were not different. Now here's the kicker is, if you work in ICUs, you're probably not going to see it for yourself. The difference in function comes after the person's out of the ICU or at the end of their ICU stay. That's when you start to see the curves split between functional recovery and not. So that's the hard part about convincing the nurses in an ICU that it's important to mobilize patients or therapists. But finally, therapists, I'm glad to say St. Louis U is finally on this. In the past year, they've got a group of early mobility team, and they're working in ICUs 7 and 8 right now. They're hoping to extend it to 9 and otherwise. And if you're worried about money, it does save money instead of cost more money. Okay, so let's get back to our patient. I'll hit the highlights here. He came to SLU in the middle of August. His real problem began back in June last year with the bunionectomy. And before the bunionectomy, he had a baseline dementia, mild, pretty ambulatory, and of course that's why they did the bunionectomy, to keep him walking. Went home, got the infection, started on IV antibiotics, went to a nursing facility mid-July. The end of July, he has another infection. They think it's a UTI. They treat him. Then he doesn't do well, still in the facility, tries to get out of bed. Obviously here he's delirious sometime in early August, stays delirious, falls and breaks his left arm. So back to where we came in. He's coming in and he stays pretty delirious for 10 days. The intervention we tried was what we always try if we don't know what to do, is antibiotics. Okay, we got to treat an infection. It's probably an infection. And really, he didn't do well. He wasn't swallowing, wasn't eating, drop off in and out. You can see the white counts smoldering there. So at some point after 10 days, he looks like this still. On day, we'll say this is day 11, the 25th. We start to question, does he really have osteomyelitis? And we bite the bullet and say, let's stop the antibiotics. And let's try something else. That's the question mark. So what do we try? We actually get him out of bed. So Matt Burr, who's here now, every day on rounds, he and I, or he and the team, and this guy we had to wear the blue gowns because he's in isolation. So it was a chore. I bet it took us minimum of 15 minutes every day on rounds, or getting him up to the Geri chair. But that was our intervention, day after day after day. And I can't tell you that's why his white count came down. But his delirium did get better day after day. His brain is upright. His brain is upright. He's up. We got rid of the PICC line. We bit that bullet. How often do you say, okay, we're taking it out? We might need it. No, take it out. Take it out. And this is about day 15 now, 16, 17, 18. Now he's starting maybe to eat. We talked about a G-tube, but we just decided to keep getting him up, and out. On the 4th, September 4th, I'll give you the follow-up 10 days later. Now here's the CT. The CT, as I told you, was done on the 27th. I think this was over the holiday. That'd be right? Labor Day, maybe? Maybe it was just the weekend. It took us 4 or 5 days to get the report back. But we stuck with our initial clinical correlation, and we said, no, this is not osteomyelitis. And in fact, when you look up here in the fine print, they give it to you. Yeah, there's no evidence of erosion. But some radiologists will always hem and haw and say, can't be excluded. But clinically we thought, no, let's stick with it. He's better. He's not having fevers. He's more alert. So we discharged him, and 10 days later, Matt followed up with a phone call to the facility. He was doing better. He was doing better. Okay. So why would I say getting people out of bed improved delirium? That's the only thing we did. We didn't start any drugs. We didn't stop any drugs. You know, we'd already tried the first 10 days of getting rid of any narcotics, any sedatives, any hypnotics, etc. So this study, you'll never guess what group of people this study was in. Oh, you guessed it. Astronauts, 30 young astronauts. And they made them lay in a bed, 6 degrees, head down. That's what the head down bed reverse, bed reverse, 6 degrees below normal. And then they would test their brain function with tests, and their cognition declined over a month. Now, they did it over a month. So you can imagine the astronauts have to lay there for a month. But they're trying to replicate being in space. They want to know what happens if you fly to Mars. Is your brain going to shrink? And the answer is probably yes. So don't sign up for that trip. These are young guys who are really in good shape, and something's happening to their brain just after 30 days of head down, decreased gravity. Can you imagine our frail, older person with already a little brain shrinkage, and you put them head down? You're not putting them in Trendelenburg, but you're putting them down. You don't get them up for 2 weeks. So this is the theory behind why maybe this person got better. And we see this all the time on rounds. We can witness this. You're trying to do a little mental status exam, where you are, days of the week backwards. The patient's not even answering. Their throat's dry. You sit them up, legs hanging, give them a sip of water, and they start talking to you. I see the geriatrician shaking their head. Yeah, just get them out of bed, they can talk. And there's the references for that. This was an old story of a patient on neurology service who had the same thing, a week in bed for seizures he never had, et cetera, and day by day the geriatric consult team took away, first we took away the pads for seizures, we got rid of the SCDs, got rid of the oxygen, got rid of the Foley, got rid of the restraints, sit him up day by day by day, and he improved in about 4 or 5 days and was able to be discharged again without any change in medications, any different intervention. Okay, the OG, the Orthogeriatrics service. Good data now. St. Louis U Orthopedics and Geriatrics will be doing a research study with Dr. Sanford leading in the near future. There's already data out there to suggest that working together with the orthopedic surgeons will improve hospital mortality as well as long-term mortality. Here's length of stay, just if you're interested. Also improves length of stay. Now, if you're interested in how many it takes, it does take a certain place that does a lot of these hip fractures to pay the geriatricians. They're already paying the orthopedic surgeons, but you've got to pay the geriatricians some amount of money to get involved and do the extra work to make it pay for itself. Here's our data. This data comes from St. Louis University. It's about a 5-year retrospective chart review. One of our students, Derek Berglund, did one of our summer research projects, like our students that are going to do this summer. And he looked at a little over 300 patients retrospectively, all hip fractures that were repaired. And we just divided the group into less than 48 hours before surgery or after. Okay. Or surgery within 48 or delayed in surgery. And we looked at reasons for delay. We already know from previous literature that it's important to get the patient to surgery within 48 hours. Just do it. Just do it. The things that delayed were, of course, weekend admission, any pre-op cardiac test, echo, except EKG, of course. But any echo, stress test, et cetera, that would delay the surgery. And a very severe ASA, people hemmed and hawed. And then now our SLUIS patient comes in, they might get put on a regular medicine service and then consult ortho as opposed to geriatric service. So if you get on some other service, it increases your risk for not going to surgery right away. Outcomes. Outcomes for delirium. A delay in surgery increased your risk for delirium, and age increased your risk for delirium. Mortality, no difference, whether you go quick or slow. Very low anyway. Nobody died intraoperatively, by the way. All these deaths were in hospital after the surgery. So just get them to surgery, very safe. Here's some unproven models. These comments are just testimonials. We need better data on the ED, geriatric ED, but I'll just make a couple comments. Patient satisfaction was off the scoreboard. Mount Sinai has some comments. Severity index. Here's somebody with a broken hip would probably qualify, but someone with acute heart attack might not. Again, these things need to be studied. What is the proper use of a geriatric ED? Right? This physician at Mount Sinai was skeptical, but let alone just for falls. We have falls in our ED. It's ridiculous. But it's because we mix and match. There's an old person down the hall, old person over there, young people. Who's watching who? Probably could decrease it. Here's some more comments. Skip that. I will like this. They thought it was a bedpan unit focused on nursing home patients. When they finally realized the unit gave better health care to their parents and grandparents, of course. This is historical geriatrics, of course. All right, now what about the geriatric trauma service? This is growing here at SLU. We've been doing this now for a while. And why are the trauma surgeons calling us now? Well, let me show you the data first before you answer that. So, overall mortality rate is about 15% among geriatric trauma patients. Age and severity, this is kind of a no-brainer. Here's the age, 74. Your relative risk goes up. Your odds ratio, I'm sorry. And it doesn't matter if you're 85 or 75 to 84. So over 74 is kind of the key age, if you want to look at age. Same in this study, in this meta-analysis, 75. So similar odds ratio for mortality, 1.7, 1.767. So pretty consistent. There was some overlap of the studies. So why are the trauma surgeons? Not because they know the data and they know we can help, but it's recommended by the American College of Surgeons now that a proactive geriatric consultation, and they describe it, and they say the guidelines anybody over 60. But we've used age 70 now for our trauma surgeons. So anybody who's doing consults every morning, Matt does it. We look in the computer now, see if anybody's over 70, been admitted to the trauma service, and we jump on the consult. Okay. We've actually had some good consults, very good consults. I think we have a better opportunity to do something different than just consult. Maybe we could round together, but we'll have to think about how to do this. Yeah.
I just know how it happens at WashU. I think it would be more effective to have full-time surgeons dedicated. Because I feel we're a little detached. We don't always have control over the medical issues. I find myself transferring the patients to medicine a lot because I'm so uncomfortable with the things I see, not being fed, given fluids at 200 cc's an hour for days.
Yeah, not getting out of bed.
This person's going to die if I don't get them transferred today. And I know I can't.
That's right.
I think we need to figure out some way to have either a nurse practitioner that's totally full service trauma or whatever eventually.
And perhaps even rounding with them, they would learn.
It would work for us because none of us can get there at 6 a.m. But ideal world.
Maybe we could do Skype rounds or something.
What I suggested to Dr. Freeman is that he would endow a geriatric salary fund.
Oh, I like that.
He didn't say no.
It does take some financial support. All right, so if you boiled all those models down and tried to pick out the best of what we've learned, here's the list. Depends on which model, of course. I'm not going to go through those. So now I will try to make an argument. Why do we need a full hospital to carry out these goals, these long list of goals? First, I would say details matter. Goal of zero and competing interests. First, details matter. I don't have to tell you about this, but finally, medicine is coming along into the business world, and people know we have to pay attention to details if we're going to be good at it. So here's our details, and we've kind of pushed them aside because they feel like, how can we change any of this? How can we change this? I'll just make a comment, cleaning people. When we first visited the ACE unit up in Cleveland in 1997. They really worked hard because it was their first ACE unit in the United States. And I remember seeing the cleaning person was part of the team. So as they were cleaning rooms, they were talking to the patient, and they would make a comment back to the nurse or the doctor. I mean, they were part of the they had, I can't remember the name they had for this person, but they were relatively integral part of the team. And then, of course, sitters who sit. We got to get rid of that. That's just beyond me. And here's something, if you had a whole hospital, you could try this on a floor, but I think we would never succeed in changing some of these things on one floor. Now, if you had a different building, maybe you could take over a whole building and do something different. And here's just some more examples. How about a proactive social work evaluation on every single person within the first 24 hours? Now, here's pie in the sky, but does the bed have to be the center? I would say get rid of the bed and put the chair there. You got to have a bed. It just goes up, goes down, goes up, goes down. Okay. One idea. There's a lot of different ways you could do this. And then what about the floor itself? You could make this a circular floor or a square. It was easier for me to draw a square. And here's how you would decrease traffic. You have to follow some rules. And people who didn't belong in there would go around and get through to there. Patients and families would be here. You'd have sliding glass doors like they do in the ICU rather than doors, perhaps. You'd have to have curtains back here because patients do have to have a window according to some regulations. But if you had a window here and window here, and you were careful about the curtains, people wouldn't be peeking in, hopefully. And, of course, no alarms. And so people out here, you could see every single patient, theoretically. Goal of zero. Why not? Why not? Why can't we go for a 0? There are other places around the world that have gone for 0. UNICEF is making progress. They've gotten down to 22,000, and then over the years they're down to 19,000. I think this group is probably going to succeed. Here's some other zeros. I just like the term getting down to 0. What about competing interests? There's really no way to compete with cancer money and cardiovascular surgery money. We all know it's geriatrics important, but how are we going to convince these folks? Now, here's one way is let's bring these patients in and take care of them under a geriatric hospital. All right. So, and this goes back to that issue is if you mix people and you're doing one thing on one floor, you know, if it's not important to every single person in the hospital, then not everyone will do it. All right, what about the other benefits? Here's some side benefits, research, education. What about CMS? Wouldn't they love to have one location where they could try something and compare it to other hospitals that don't have this? Whether it's falls. I love the green path. I get the term green path from the Chinese. If you call someone and they let you in the hospital immediately, that's called a green path. So rather than 3.5 hours or 8 hours in the ED, wouldn't it be great to say, bed 816, come on in. Make a decision over the phone or use the telemedicine technology to say they meet criteria, bring them on in. And then education, of course, you would need specialists in a geriatric hospital. You need your orthopedic surgeons. You need your trauma surgeons. You might or might not need your neurosurgeons, I'm not sure. But you need some specialists, oncologists, cardiologists maybe. And then other healthcare professionals. Okay. And I guess my last slide, I guess I'd say, why not? Why couldn't we be the first? So, all right. So, thank you very much. So, open for comments, questions. Yes, Angela.
I have a question about this hospital and the sitters. Do you know, has anyone ever discussed this problem? You're right. Like, I imagine the sitters talking to my old person and becoming friends and ward off delirium, prevent falls, they're getting them up, helping them to the bathroom. That's sort of my envision of what a sitter is. I base it off of like my children's babysitters. But in our hospital, it's like I can't touch the patient. I don't touch. We're not allowed to touch. And then the sitter's like always on their phone. So it's not helping prevent delirium. It's not helping prevent falls because you can't touch them.
Right.
You know, like, has anyone ever addressed this with the hospital administration?
I've discussed it, but I haven't gone anywhere further with that. That's
Because we could, I mean, that could change. It doesn't have to be that way.
absolutely, absolutely.
But they did have
Yeah, Marcia.
care partners and nurse assistants who were a large number of the sitters. And then they start bringing
Yeah.
individuals in from other departments. So they bring people in from dietary and from central supply and things like this. And even sometimes, occasionally, they would have volunteers. And that's kind of when they came in with the no touching the patient, and that you're there to just sit there and listen. Because those could be the volunteers that would walk the patient.
Absolutely.
And wear them out and then be tired and leave.
Marcia, I mean, how much training do you think someone would need to be a good care?
Skills, it has to do with reliability.
It seems like we could tap into that.
Yeah, absolutely.
People are just afraid to give patients up. So, Joe,
The
we
fi-
have a simple thing. It's okay to tie people down in hospital, but it's not okay to walk them. It's not okay to talk to them. It's not okay to do anything.
Right.
Where's the problem? The problem is first us, because we as geriatricians need to have insight and realize this is the problem, and the geriatrists have an even bigger need because they should understand that people are mind as well. But beyond that, it's an administration. And it's not only we, but it's virtually every hospital in the United States has an administration who believes that doing bad things to patients is good. And I can give you 100 examples, as you know.
I know.
And the reality is we've got to complain and we've got to be active.
I would agree, but
And I will point out that
we've been doing it for 20 years.
Some, like you, do an awful lot. Others don't make much effort to change the situation. And it's really each of us are responsible when we're on the floor to decide how much we want to change
So what's the roadblock of getting the change? I would argue the culture is such uphill that we could try till we're both dead. But until the original GEMU in UCLA, the reason, I think Doug Miller told me, one of the reasons it worked is they had control. They had control of the whole unit. And without control, and this goes for all geriatric models, if you lose control and you give it up and things start to change against what you believe and what the principles are, then it's diluted. Just like the GEMU trials that they did the multi-site trial. They had no control. They tried to do the principles. So I would argue the only way to make a big change would have control over every aspect from check-in to check-out.
So cardiologists have this control, surgeons have a lot of this control.
Sure, that's competing interests, John.
Here's
The problem is cardiologists make a huge for the hospital. Surgeons for the hospital. What do we do for the hospital?
We make a lot of money for the hospital.
Indirectly. I would say indirectly.
Actually, the hospital did this when
Yeah.
thinking of actually giving us a geriatric area, which would have been close to what we wanted. Basically, they looked at the costs we saved, and it was a fortune.
Totally. Yeah.
There are many adverse incentives, perverse incentives going on here. I mean, it's been shown, we can shorten hospital stays, we can reduce the number of events that will result in the hospital getting sued, people breaking their heads, falling out of bed. We can do that, okay? But there's a better way. And that's shrink your hospital and get rid of general medicine beds. And then you get all these bad people who get up in the middle of the night and start looking for their mother and running for the elevator. Unpleasant. And you just make it so they can't get in. Okay? Oh, you can't come in our hospital because all 11 of our general medicine beds are full. We'll have to send you to one of our fine community.
So that's what's happening, right?
No, let's not go there for the other crowd. We can talk about that at a faculty meeting. I see where you're going, and we need to discuss that. Yes. That's intra-politics. That's the SSM relationship.
The hospital is they're trying to go to the bathroom. And we insist that they push a button and call for a nurse.
Now you're
and
talking.
it's coming. Where the technology is there. You can push a button and the toilet will come on its own.
There you go. Now you're talking. Now you're talking. Now you're talking. Dr. Tadros. Dr. Tadros.
We think the medical team, used to be the medical team was the student and the resident, the fellow, the attending. And then we started talking about different things where we include social workers in certain situations and now sometimes housekeeping and other things. How about including the business people, the money people, the finance, because it always comes back to money in some and then the risk managers. They're for me, that's part of the clinical team in a roundabout way. They never at the table as we talk about it after the fact, whenever something adverse happens. So one of the things that I'm interested in is expanding it. It doesn't have to be on grounds or everything else.
Sure,
Just
sure.
concepts. Because they sometimes are the hurdles, they're the bumps in the road sometimes.
I wonder if there's any models out there where the CEO rounds once a week or something. I've had a couple meetings with CEOs for this hospital in Des Peres, and I always insist, I won't meet you at your office, I'll meet you up on 9 North, and we'll just walk around for 20 minutes when we talk. And one time the CEO we're talking about space for residents, and he's walking around, I picked right at round time on purpose. He's like, I counted 50 white coats. You guys don't have any room up here. I said, oh, really? That was about the meeting. So yeah, getting CEOs out of their house, out of their room, out of their comfort zone, I think it's a good idea. Yeah, finish.
Just like a trip across the street to talk about women, they do all this stuff.
They do, don't they? Yes.
Children, because they're humanized differently, I believe.
Great point. Great point. Great point.
They can do it. It's possible.
So the first pediatric hospital was in the mid-1800s. I think somewhere Pittsburgh or Philadelphia. I can't remember. Do you remember Philadelphia? Maybe Philly. Yeah, where's Paniagua? Where Philly, okay. And I don't know the history behind it, but, again, he was a little bit off the edge. It was like, this won't work. I don't know why she would do it.
Children are entertained. They're at tables. They're talked to differently. The whole atmosphere of the hospital.
It is. It even impacts residents and students. If there's any residents or students who have rotated over there, it's a big difference even for physicians. You feel different. Now, I wouldn't suggest a geriatric hospital belittles elderly. You have to make it very respectful, but there's ways to do it. We've been doing this in nursing homes forever. Seems not forever, a couple decades, where we bring the human part of it into the nursing home and make it their home. Why do people wear gowns? Elderly people should wear what they wear at home. A lot of things we could change, yeah. That's a good analogy, PH. Yes?
Joe, have you read much about family involvement as far as protocols, what they can do, what they can't do, what they should be allowed to do? I think that's an untapped resource.
That's a good point.
That we're looking into in the ICU.
Yeah, I have not. The group in Vanderbilt, I told you, they added the F to the ABCDEF.
A lot of that is family involvement in rounds, but, why couldn't some family members do passive range of motion or even active? I don't know if you've seen anything about family-assisted ambulation in the wards or anything like that.
I have not. Let me look. That's a good idea.
Yeah.
That
My
and
first
feeding.
question went out to the lawyers.
You bet.
What's the liability? And so I haven't heard back from them. You
Interesting.
always wonder about that. Worst case scenario.
In most of the world, the families are doing this. It's only here that they're regarded as the enemy.
Yeah, is it like countries like India, they bring the food in. They, So maybe you're onto something. I think the family involvement.
So I teach all my patients that fundamentally, if somebody comes into hospital, somebody has to be with them 24 hours a day, and they have to ask why everything is happening. They should get involved, and if they don't do that, then they don't deserve their loved one to have a good outcome. And I can tell you when I've been in hospital, I did that, and it saved me a lot of problems using one of the advanced practice nurses who worked with me, because they wanted to do things to me that were really stupid. And most lay people understand stupidity. Physicians just don't have any concept of what stupid is. And everything Joe's talked about is really, if you think of it, what we do is stupid. And yet we go to the administrators and we say, this is stupid, you shouldn't do it. And they say, oh no, this is the way we do it, you guys don't know. And we are shrinking violence and sort of say, well, yes, we're just geriatricians. My belief is geriatrics is a super specialty. We are the only important people for older people. The rest of physicians are minute players. We need to teach people that, because if we don't do that, we'll never get anywhere. And then we need to broadcast the things that are wrong in the hospital. Treneton did a wonderful job, and he really made big changes around the country and made people think by just writing one article saying, look, what you do in hospitals is terrible. And I think we have to tell the lay public that what we're doing is terrible. And if we tell them it often enough, the hospital will start to listen, because the hospitals don't like you to tell the lay public that they're doing poorly. I think some of us here understand that one, but it's how we got an ACE unit. I used to write in the chart all the time. I will phone the post-dispatch, and I will call the police for you restraining people in the hospital.
Well, when I did that, they called it code gray.
We understand, but what I'm trying to tell you...
On you? You guys have code gray? Code gray is when the police come. The security. It's usually for families who are out of control.
On LinkedIn, we're trying to do this because I think it's
Let's
don't sell what's right. You most probably deserve it.
So I'm turning this off. Okay. All right. Thank you all very much for coming. Let's close there. Thank you.